Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. In the last few very important session, we have discussed all the clinical based, scenario based, one-liner and very important questions plus concept plus golden point chanting. So similarly, in this today's particular video also, we are going to discuss such a very high yield and very important clinical based, concept based, and the questions which will directly strikes in your exam in your computer screen. So those questions with complete clinical discussion and very important golden points chanting we will do in this today's particular session. So my point is very clear, to give you a very high yield content and the very important content for the exam. And I want every one of you to take a note of the very important point what I am explaining. Especially wherever I am explaining, it is very important. Please consider that one as the very important and practice that one at least 2 or 3 times, because it will strike in the exam, right? So with this particular very important information, we will start the today's session. Okay, so before going to the information, here is the beautiful motivational line for you all. Students, the task which is ahead of you is never greater than you. The strength within you is always greater than anything which you are going to face. Okay, so whatever the exams you are going to face in the next 1 month, that may be a Norcet exam and any other exams, so which is not greater than you. Yes, it is not more than your strength. Your strength is always greater, your strength is always superior, and you have to believe in that one. Yes, that will give the result, right? So don't think exam is more than you. Okay, it's not more than you. It is possible. If you have feel that you can do that, so you will do that. So that is the very simple thing, right? So with this motivational line, a very good evening, beta. Very good evening to one and all who have joined to the live session. So फटाफट hit the like button, and who all are live to the session, so please do thumbs up in the comment box. We will start the today's session, right? Very good evening to every one of you. Hope the content what I'm giving is very much helpful to every one of you, and which is boosting your actual preparation for the Norcet exam. And wherever I am explaining better, this is the very important question. So please consider that one as the very important point, and practice at least 2 times or the 3 times, or just take a screenshot or revise at least 2 times. Yes, it is important, then only I am telling you. Yes, very good evening, very good evening. It is important, then only I am telling you. It is very important, right? So here is a simple information. Any one of you are preparing for the Norcet 9 and searching for a great test series for the Norcet 9, here the Super 60 test series is available for every one of you. This test series, which includes all the very important multiple choice questions which is necessary for your upcoming exam with the same exam pattern practice. Okay, so here we are giving the a 20 non-nursing question plus 18 nursing question in one particular test. Okay, this particular exam will be live since morning 6 a.m. to the 11 p.m. and at 11:30 p.m. you will get the all India rank. Okay, so this is the specialty of the Super 60 test series. Okay, it contains all the clinical based, scenario based, practical based, and the question which is much necessary to practice for your Norcet exam. Everything we have integrated in the Norcet Norcet Super 60 test series. If you want to become a part of this one, please download the Master Nursing Classes app. I have given the link in the description box. Okay, and for the all updates, if you want for your Norcet exam, which including all the non-nursing questions which is necessary to study before the exam, and most important like one-liners and the updated things in the pharmacology community, whatever you want, if you want before exam is, so please join to our WhatsApp channel. I have given the link in the description box. Okay, every day you will get the a very important golden point for your exam. Okay, so and whatever the classes I am sharing in the WhatsApp channel on the daily basis in the morning, so please don't neglect those classes, because those are very important classes, and the short period I have covered the huge a very important syllabus that is necessary for your Norcet prelims and mains exam. Okay, so without wasting the time, we will start the today's session. Here's the first question which is coming in front of you all. So please do read the question completely and give the best shot in the comment box. Yes, the question is very simple. Antepartum hemorrhage is defined as bleeding from the genital tract. Okay, and option A, that is after the 12 week of the gestation. Beta, if bleeding which is happening in the first trimester. Okay, so that is what we call. There are the three reasons for that one. Okay, if the first trimester bleeding or in the early second trimester bleeding, there are the total three reasons are there. One, it may be abortion, or another it may be a ectopic pregnancy, or another it may be a very important our molar pregnancy. So if the bleeding is happening in the early pregnancy, think about these three things. Okay, if bleeding happening after 28 week, okay, after 28 week, always that is the antepartum hemorrhage. Okay, in the antepartum hemorrhage we will study the two very important thing. One is our placenta previa, another one is our abruption placenta. Very important for your exam. Okay, one is our placenta previa, another one is our abruption placenta. Yes, a third trimester bleeding is due to the placenta previa, or the bleeding which is third trimester is due to the placenta previa and abruption placenta, and bleeding which happening in the early pregnancy, that may be in the first trimester, or it may be in the early second trimester, or it may be in the early second trimester. Always think about these three very important things. It may be a bleeding due to maybe abortion, bleeding due to maybe a ectopic pregnancy, or bleeding may be due to the molar pregnancy. Okay, so in our question what they have asked, yes, they have asked the criteria to define the antepartum hemorrhage. Okay, yes, the antepartum hemorrhage is a hemorrhage which happens through the genital tract, okay, after the 28 week of the gestation, and many of you have given the correct answer. The hemorrhage which happens after the 28 week of the gestation up to the delivery. Okay, up to the delivery. So this is called as the antepartum hemorrhage. And option C, which is telling a 24 week of the gestation and after delivery. But after delivery bleeding is happening, so we call that one as the postpartum hemorrhage, which is not an antepartum hemorrhage, right? If after the delivery bleeding is happening, we call that one as the postpartum hemorrhage. So I'm eliminating the option C. Then the first trimester, so this is not going to a correct answer, right? So the very important thing to diagnose the antepartum hemorrhage is the bleeding which happening per vaginally after 28 week of the gestation, we can say up to the labor process begins. Okay, this is what we call as the antepartum hemorrhage, or else we can say that is a very important bleeding per vagina after period of viability also. Okay, after period of viability. So in India, period of viability in India is the 28 week. Okay, so this is also a definition of our a very important antepartum hemorrhage. Okay, so remember very important points here. Okay, so the thing what I had told here, a bleeding is happening in the pregnancy. If the bleeding is happening in the first trimester or in the early second trimester, the cause may be abortion, the cause may be ectopic pregnancy, or the cause may be a molar pregnancy. Okay, if in case the bleeding is happening in the third trimester, so it may be due to the antepartum hemorrhage. So we call that one as the antepartum hemorrhage. It may be due to the abruption placenta or placenta previa, right? So what is the abruption placenta? What is the placenta previa? So remember, beta. So what is abruption placenta and what is the placenta previa? So this is the our uterus, normal uterus in the female. So this is the uterus, and here are the fallopian tube. You know, this is the general diagram of the uterus. Okay, so usually the placenta should be attached in the upper uterine segment. Okay, usually the placenta should be attached in the upper uterine segment. If the placenta is attached in the lower uterine segment, we call this one as in the placenta previa. What we call this one? This one what we call as in the placenta previa. Okay, so this is our normal placement of the, okay, so normal placement of the placenta. If the placenta belongs or blows in the a lower uterine segment, we call that one as in the placenta previa. Okay, so this is what we call placenta previa. So then what is the abruptio placenta, sir? Sir, very simple abruptio placenta. Remember, this is the uterus. Okay, so this one is the placenta, right? So this one is the placenta which is attached to the our uterine wall. This particular placenta, normally it will get separated from the uterus at the third stage of labor. Okay, at the third stage of the labor. Normally when the placenta will separate from the uterus, normally the placenta will separate from the uterus at the third stage of the labor. If in case before the beginning of the labor or before the third stage of the labor, at the age of the 34 week of the gestation, at the age of the 32 week of the gestation, in that particular phase, okay, before the onset of the labor, if the placenta is get separating, we call this one as in the abruptio placenta. Okay, so the placenta is get separating. Okay, so placenta is get separating before the 37 week, or the placenta is get separating before the third stage of the labor. Okay, so this is what you call as in the abnormal separation of the placenta, or that is the abruptio placenta. Okay, very important. Hope it is clear to every one of you, right? So here is the next question. The basic concept regarding the both the definition I have clear to you. Okay, so now please do mention the correct answer for this particular question. Which of the following is most common cause for the antepartum hemorrhage? Okay, so which of the following is the most common cause for the antepartum hemorrhage? Okay, option A is the vasa previa, option B is the uterine rupture, option C is the placenta previa, and option D is the placental abruption. So what is the correct answer? I am waiting for your answer in the comment box. So fatafat, who all are watching the video, fatafat do response to the particular question in the comment box. Yes. Which of the following is the most common cause for the antepartum hemorrhage? The options are given like this. Okay. Yes, beta, the vasa previa also causes the antepartum hemorrhage. Uterine rupture also causes the antepartum hemorrhage. Placenta previa also causes the antepartum hemorrhage. And the placental abruption also causes the antepartum hemorrhage. But the question is, which one is the most common cause? Okay. So to remember this one, okay, here I will tell one trick, a simple trick. Remember, okay, so antepartum hemorrhage which happens due to the abruptio placenta. Okay, so remember AP and AP. So what is AP? Antepartum hemorrhage. Okay, and which happens due to the abruptio placenta. The most common cause for the abruptio placenta, sorry, the antepartum hemorrhage is abruptio placenta. Search for the answer. Option A, vasa previa. Beta, vasa previa also it happens, but it is not most common. Okay, so here's the option D goes to the placental abruption or the abruptio placenta. So that is the very important point. Remember, antepartum hemorrhage happens due to the abruptio placenta. So what are the another name of the abruptio placenta? Okay, another name of the abruptio placenta. Can anyone wants to answer in the comment box? Yes, fatafat do comment your answer. What is the another name of abruptio placenta? What we can say, another name? Yes, fatafat. I'm waiting for your answer. Another name of the abruptio placenta? Fatafat. Comment your answer. Yes, whether it may be a right, whether it may be a wrong. So your active participation is more important for retaining the things what I'm explaining to you. Okay, so whatever the thing I'm explaining to you, if you want to retain that one in your mind, so your active participation is most important. Okay, so if it is a wrong question or if it is the right question, that doesn't going to matter. If you are participating means it will it will stick in your mind and it will help in your exam, right? So another name of the our abruptio placenta. Okay, so one name we call this one as in the accidental hemorrhage. Yes, correct. We call this one as in the accidental hemorrhage. And another name for this one is the very important. Yes, anyone wants to answer another name? Yes. Yes, that is the uterine apoplexy, we can say. Okay, so very important. You have to just remember one name. So that is the accidental hemorrhage is the another name for the abruptio placenta. Okay, so why it happens? Abruption placenta. Why? Because some accidental, unavoidable situations like, okay, the pregnant lady who is going on the bike, okay, suddenly she fell out of the bike and there is the damage to the abdomen. So that time there is a chance of the suppression of the placenta. Okay, so always in the abruption placenta there will be a history of the trauma will be there. Okay, so remember, very important point. In the placenta previa bleeding, there is no need of the history of the trauma. But whenever we are asking, whenever we are assessing the patient for the abruption placenta, we should and must ask for the history of the trauma, like a previous small accident or any blunt trauma to the abdomen. So that is separating the placenta from the uterine segment. Okay, so very important. Another name of the abruption placenta is the accidental hemorrhage, or you can also remember the uterine apoplexy, but that not that much important. But accidental hemorrhage may be the word, it may come in your exam. Okay, so don't confuse abruption placenta and accidental hemorrhage are the same thing. Okay, so hope this trick and another name is very much helpful to you. Okay, so here is the golden point chanting for every one of you. The causes of the antepartum hemorrhage. Remember, there are the total three causes. One is placental causes, and one is the cause that may due to the fetal problem, and then some are the local causes. Okay, so in the placental causes you have to remember the three things. That is the cap. That is the cap. Okay, so what is the cap, sir? C stands here is the circumambulate placenta. Okay, A stands here is the abruption placenta, and the P stands here is the placenta previa. Right. So placental causes are the like circumambulate placenta, and placenta previa and abruption placenta. Remember the cap, that is for the placental causes of the antepartum hemorrhage. Okay, and note the battledore placenta. Battledore placenta will never causes the antepartum hemorrhage. Remember, okay, so there is no any bleeding from the battledore placenta. Okay, so battledore placenta will never ever causes the antepartum hemorrhage. So it may be comes in your question, and this is the a point where you have to exclude. Okay, so very important, keep in your mind, right? So then comes to the fetal causes. In the fetal causes, the vasa previa means the bleeding is happening from the fetus, that may be due to the velamentous insertion of the placenta. Okay, so here the velamentous insertion of the placenta means the umbilical veins and vessels which will first attach to the membranes, then it will goes to the placenta, where if the fetal membrane get ruptures, that time the umbilical vessels also will ruptures and the bleeding will happens. So the bleeding which happening from the fetus, we call that one as the vasa previa. So very important. So bleeding which happens after the like 28 weeks and in the late third trimester. So it may the fetal causes of the antepartum hemorrhage is the very important, that is the vasa previa. Okay, so due to the local causes also our very important antepartum hemorrhage will happen. So, okay, so it is the cervical polyp or the trauma to the our cervix which may leads to the antepartum hemorrhage. Okay, so remember the very important point. Yes, in the placental causes of the antepartum hemorrhage, I am remembering the cap. Circumambulate placenta, abruption placenta, placenta previa, which may bleeds in the third trimester and which causes the antepartum hemorrhage. Okay, sir, which placenta will never causes the antepartum hemorrhage? That is the battledore placenta will never causes the antepartum hemorrhage. Sir, what is the battledore placenta? Yes, what is the battledore placenta? But in the OBG video sessions, I have covered all the placental disorders with image based questions, everything. So it's okay, which are already available in the YouTube channel. You can watch that one in the free. Okay, so what is the battledore placenta? Yes, the battledore placenta is very simple. Consider, so this is the normal placenta. Okay, so here is the maternal membrane and here is the fetal membrane. Towards the fetal surface of the placenta, exactly at the middle of the placenta, the umbilical cord will attach. This is what we call as the normal. Okay, this is what we call as the normal. Okay, so what happens in the battledore placenta? So here, this is the maternal surface and here is the fetal surface. Okay, so to the fetal surface here side, okay, to the side the umbilical cord is attaching. Umbilical cord should and must attach actually at the normally at the center of the placenta. If the umbilical cord which is not attaching to the center of the placenta, it is attaching to the periphery of the placenta. So that is what you call as the battledore placenta. Okay, remember in this particular battledore placenta, so there is never ever any incidence of the antepartum hemorrhage. Okay, remember the very important points, right? So hope it is clear to every one of you. And here is the next question which is there in front of you all. So please do read the question carefully, completely, and try to give the best answer in the comment box. I am waiting for your answer in the comment box. Yes. The question is, a 32-year-old woman gravida 3 parity 2 at the 35 week of the gestation. Okay, so what is the gestational age here? Gestational age is she is a 35 week gestation. Okay, and she is now presents with a painless bright red vaginal bleeding. Okay, and she is hemodynamically stable. What is the most accurate diagnosis here? Students, remember, whenever we are differentiating the abruptio placenta and placenta previa, so these very important points you have to remember in the mind. Whenever in the question you will find it is painless, always your answer should goes to the placenta previa. Whenever you will get the word that is the a bright red vaginal bleeding, okay, so that is at the third trimester, bright red vaginal bleeding and the painless bright red vaginal bleeding, your answer always should go to the placenta previa. Why? Because in the abruptio placenta, bleeding will happens like this. So how, sir? That is the dark red color bleeding will be there, and which is painful bleeding, very very important point, just keep in your mind, which is painful bleeding. So dark red color painful bleeding means your answer should go to the abruptio placenta. Okay, so the painless bleeding which is bright red in color, so your answer goes to the placenta previa. Very very important point, just keep in your mind, right? So intrauterine fetal death and the abortion which will not happens here, because the what we can say, the age of the gestation is 35 weeks here. Okay, so the abortion usually happens in the early pregnancy. Okay, so that is before the period of the viability, and IUFD will happens, but it will not carry till the late third trimester. Okay, it will terminate easily, and in the IUFD there is no any evidence of the vaginal bleeding. Okay, it may be comes rarely. Okay, so yes, there will be chance of vaginal bleeding, it is a rare condition. Okay, so here they have clearly mentioned that is the painless bright red vaginal bleeding at the third trimester, so answer always goes to the placenta previa. So this is the a golden point table for every one of you. Okay, this is the very very important table for every one of you. Okay, so just try to remember the thing what I am explaining. Okay, so in the placenta previa, so this side whatever the characters are there, this is the placenta previa, and here are the abruptio placenta. Okay, so means in the placenta previa, it means there is in the placenta which is there in the lower uterine segment, so that is what we call the placenta previa. And this side abruptio placenta means a placenta accidentally gets separated from the uterus before the onset of the third stage of the labor, or the before the onset of the labor we can say. Okay, so very very important, just keep in your mind, right? So in the placenta previa, definition is already I have explained. So there is the placenta incompleted in the, or sorry, placenta implanted in the lower uterine segment. Usually it should be in the, normally it should be in the upper uterine segment. Now the placenta is in the lower uterine segment, so that is the reason I told this one is in the placenta previa. Okay, and which will covers the cervix approximately. Okay, so like it will covers the cervix half or the full, or at the margin, or at the lateral portion. Okay, so based on that one we will divide the type of the placenta previa. Okay, next I will explain the type of the placenta previa. Okay, so then in the abruptio placenta what happens, which is a premature separation of the normally implanted placenta. Okay, so normally implanted placenta should separate at the third stage of the labor. Okay, here it is separating prematurely, so that is what we call as the abruptio placenta. Keep in your mind, the very important. Okay, so onset of the bleeding, it is sudden. Okay, so onset of the bleeding which is sudden and which is recurrent, right? So here in the onset of the bleeding in the abruptio placenta, which is also sudden, but it is not recurrent. Okay, it is not recurrent, it is one time. So what you mean, sir? So I mean here in the placenta previa. Okay, so in the placenta previa, here the lower uterine segment, so this particular placenta will bleed today. Okay, and for the tomorrow there is no bleeding, right? And the day after tomorrow there may be a bleeding, and the next day there may not be a bleeding. Okay, so bleeding is there, and here no bleeding, and again bleeding is there, and here no bleeding. So this is what we call as the recurrent bleeding. Okay, so which is not continuously and one time. In the placenta previa, there will be a recurrent bleeding. There may be a recurrent bleeding in the placenta previa. But in the abruptio placenta, whenever it gets separates, okay, so there are the two types of the placenta are there in the abruptio placenta. One is concealed type, another one is the revealed type. Okay, so in the concealed type, the placenta will get separates, okay, and it will not allow the blood to come out. Okay, so it will hold the blood here only. Okay, so only placenta, it will separates from the middle portion from here, and here it is attached, here it is attached. So whatever the bleeding which happening, which will collects here in the backward portion of the placenta. Okay, so this is what you call the concealed. Okay, means it is hidden type, or we call this one as the concealed type of the placenta. Okay, so concealed type of the abruptio placenta. And one another type, consider this is the uterus. Okay, and here is the placenta. Okay, which is separated, and blood is coming out of the vagina. So this is what you call the revealed type. Okay, so this is what you call as the revealed type. Another one it will come, that is the mixed type. Okay, so another one which is the mixed type. So total how many type of the abruptio placenta? That is the concealed one, and the revealed one, and the third one is the mixed one. Sir, among these three, which one is most common, sir? Beta, always mixed type of the abruptio placenta is most common. Okay, so most common type of the abruptio placenta is the mixed type of the abruptio placenta. Remember, okay, so here it is one time bleeding. Okay, so which is sudden bleeding. In both placenta previa there are the sudden bleeding, but in the placenta previa and abruptio placenta there is a sudden bleeding. But in case of the placenta previa, the bleeding will happen recurrently, means today, and then there may be a 1 day gap or the 2 day gap, and again next day bleeding will happen. Okay, but in the abruptio placenta, once it's separated, it will end. Okay, so it will end as in the premature labor. Okay, so that is a very, very important thing, just we have to keep in our mind. Okay, then the type of the bleeding. So this is what significantly differentiating feature between the abruptio placenta and the placenta previa, and your examiner favorite point. So that is the painless bleeding and bright red vaginal color bleeding, so which will be seen in case of the placenta previa, and painful bleeding, dark red vaginal bleeding, so this will be seen in case of the abruptio placenta. Sir, why, sir? Why means, sir, here in the placenta previa, so the blood which is coming here, it is which is the fresh blood, so that is the reason this blood is a very, very important fresh. So that is the bright red blood. Okay, so that is the fresh and the bright red color blood it will come. Sir, in the abruptio placenta, whatever the blood which is coming out, sir, that is the blood which is already bleeded and which have been stored and which is coming out, sir. So this is the dark red color bleeding, sir. So this is the dark red color bleeding, sir, this one. Okay, so very, very important, keep in your mind the dark red color bleeding. So that is the abruptio placenta. A bright red color bleeding is the very, very important placenta previa. Okay, so along with this, here the placenta separated, sir, means here the thromboplastin will release, sir. This thromboplastin, okay, so it will contract, it will start to stimulate the inflammatory marker, and it will start to contract the uterus, sir. So that is the reason in the abruptio placenta pain is there, but in the placenta previa, which is the painless, very, very important. Comes to the point of the differentiation. So the placenta previa is the painless and abruptio placenta is the painful. Okay, so here is the bright red vaginal bleeding is there, and in the abruptio placenta dark red vaginal bleeding is there. So this is your examiner favorite point. Okay, so many times questions have been directly asked in your exams. Okay, so very, very important, keep in your mind, right? So next comes to the uterine tenderness. Okay, so uterine tenderness, there is no any uterine tenderness in the placenta previa. So due to the release of the inflammatory markers, there is a tenderness in the abruptio placenta. Okay, and the uterine tone, here it is the soft and relaxed uterus there in the placenta previa. Okay, in the abruption placenta, which is firm and rigid, tenderness will be there. Okay, so very important. Remember, in the abruption placenta, there is in the uterine tenderness is there, and the uterus is very much firm, which is rigid and which is tender. Okay, so the very important point of the discussion here, so that is, in case of the placenta previa, in case of the placenta previa, what happens? The uterus is soft. The uterus is soft. Okay, and if you want to assess the fetal heart sound, it can, we can easily hear. Okay, we can hear that one easily. And if you want to palpate the fetal part, okay, so if you want to palpate the fetal part, so you can palpable. Okay, which are palpable because the uterus is soft. But in the abruption placenta, but in case of the abruption placenta, what happens? So uterus in the abruption placenta is rigid and which is tender. Okay, so this is the reason in the abruption placenta, so it is difficult to hear the fetal heart sound. Fetal heart sound are not audible. Very important. And fetal part unable to palpate. Unable to palpate. Very important. Differentiate between the, again, placenta previa and the abruptio placenta. Remember, so this will be our exam question. Okay, so the next point of the differentiation is contraindicated exams. Okay, so in the placenta previa, the pervaginal examination is contraindicated. Why? Because, so here in the placenta previa, the placenta is located in the lower uterine segment here. If we are doing the pervaginal examination, if by mistakenly, okay, pervaginal examination means we will insert the finger in the vaginal cavity. If by mistakenly this finger, if we enter the cervix, means there is a chance of the bleeding is there. So that is the reason. Okay, so in the placenta previa, the pervaginal examination is contraindicated. But in the abruptio placenta, we can do, but with caution. Okay, so in the placenta previa, the digital vaginal examination is contraindicated, or the pervaginal examination is contraindicated. PV is contraindicated. Okay, very important. Keep in your mind. And in the abruptio placenta, we can perform that one pervaginally. Okay, so but with caution and with some precautionary measures, we have to perform this particular very important PV examination in the abruptio placenta. Okay, so complications of the placenta previa and abruptio placenta are like this. Okay, so most major complication of the abruptio placenta is disseminated intravascular coagulopathy. Okay, so DIC is the most and the major complication of the abruptio placenta is the disseminated intravascular coagulopathy. So that is the reason whenever senior obstetricians are there, so if the patient they found with abruptio placenta, they will prefer to deliver that particular fetus as soon as much possible, because they want to avoid the disseminated intravascular coagulopathy. Okay, if in case by mistakenly if we done late in the delivering the patient with abruptio placenta, so the patient may land into the disseminated intravascular coagulopathy due to the activation of the thromboplastin. Okay, so all the clotting factors will consume and the bleeding will start to happen. Okay, if the bleeding is happening and the coagulation profiles become abnormal, means we can't do anything that time. Okay, so LHCS also contraindicated if the coagulation profile is abnormal. So that is the reason. Okay, so whenever the patient we will found with the abruptio placenta, always keep in your mind, always prefer the patient to deliver as soon as possible in order to avoid the disseminated intravascular coagulopathy. By mistakenly the DIC happens means, so that time again we need to go for the correction like fresh frozen plasma, cryoprecipitate we need to give, we need to replace the coagulation factors, and then we have to go for the LSCS. Okay, so that is the time consuming process. Okay, so remember. Then a placenta previa, the preterm labor may happens. Okay, preterm birth may happens, hemorrhage may happens, and abnormal placental adhesions like acrita, it may happens. Okay, so in the abruptio placenta, okay, so fetal distress and fetal death and maternal shock may happens. Okay, so very important, because in the abruptio placenta there will be heavy bleeding will be there. Okay, so heavy sudden onset, one time heavy bleeding. So that is the reason the maternal shock may happens in case of the abruptio placenta. But in the placenta previa, initially there will be a little bleeding, so it will give warning. So warning hemorrhage, it will be present in the placenta previa. So in the abruptio placenta there is no any warning hemorrhage. Sudden onset, sudden and the huge bleeding. So in the abruptio placenta. In the placenta previa, there will be a warning bleeding followed by a vaginal heavy bleeding will be there in the placenta previa. Okay, so in the placenta previa, there is a warning hemorrhage present. Okay, so warning hemorrhage which is present in the our placenta previa and which is absent in case of the our abruptio placenta. Here there is no warning hemorrhage. Suddenly severely huge bleeding will happens in the abruptio placenta, but the warning hemorrhage will not be there. Okay, so but in the placenta previa, initially little bit bleeding will happens followed by the huge bleeding, means the warning hemorrhage will be present in the placenta previa and there is no any warning hemorrhage in the abruptio placenta. Hope the golden point chanting what we have done between these two are very much helpful to every one of you all. Okay, so beta I think it's a very clear explanation, right? Yes, Padafat do thumbs up if the concept is clear. Padafat do thumbs up. Remember this particular concept what I have explained to you people, definitely this concept will be printed in your Norcet prelims or in the mains. Definitely 1, 2 or 3 questions you will get in this particular explanation what I have did here, slowly, perfectly, carefully to every one of you, right? So Fatafat do like to the session if you found the content helpful, right? So here is the next question waiting for your brilliance. Yes, show your excellence in the comment box because you are the excellent students of the master nursing classes. You are attending the class very daily basis with consistency. So better this consistency only is your power. This craving to get the government job. Okay, so this is our power. And this craving to get the knowledge. Okay, so some students are like they are not going to appear in the exam, but still they used to watch the class for the knowledge. Okay, so this is your power, right? So craving to get the knowledge is your power. If you have the knowledge, means yes, you are a powerful person in the world, right? So knowledge is the power, right? So Padafat show your excellence in the comment box, whether it may be a wrong, whether it may be right. So please try to do comment in the comment box. Okay, so why? Because it involves your complete mind in that, right? So here's the question. Yes, already we have discussed this particular thing very clearly in detail. Yes, very nice of you. Many of you have given the correct answer. There is the just scenario I have explained in front of you. So that was look at this one, 35-week gestation, painless, bright red vaginal bleeding, placenta previa. Okay, so similarly in that particular situation I have told dark red bleeding, painful bleeding. Okay, so that will be seen in case of the abruptio placenta and many more things we have differentiated here in this particular table. Okay, so the question is here again the very simple, right? So with lots of the clue to choose the answer. Okay, so how many clue we have in this particular question? Let's search. Okay, so here there is a 30-year-old woman and she is 34 week of the gestation, means she is in the third trimester, first clue. Okay, and she now presenting with the sudden onset of the abdominal pain. Okay, beta pain is there here. Okay, so the placenta previa is the painless vaginal bleeding. Now it is pain is there, so I am eliminating the placenta previa. Okay, so then comes to the point, second point, there is a uterine tenderness is there. Yes, I told in the abruptio placenta there is uterine tenderness is there, so that is the reason the tenderness and rigid thing is there in the abruptio placenta. So because of this we are unable to hear the fetal heart sound and we are unable to palpate the fetal part. Okay, so this thing I have explained. Yes, in the question they also they have given the clue, the uterine pain is there, uterine tenderness is there and dark vaginal bleeding. Okay, so the fresh red vaginal bleeding, placenta previa, dark vaginal bleeding, that's our abruptio placenta. Remember. Okay, so very important point with lots of the clue to choose the correct answer. Okay, so hope you people understood the particular point type explanation here. Yes, so well done of you. Okay, yes, the vasa previa may also bleed, uterine rupture also may bleed like this, but the classical dark vaginal bleeding with the tenderness and the pain in the abdomen is the classically seen in case of the abruptio placenta. Hope it is clear to every one of you, right? So the next question is here, and yes, Fadafat do comment in the comment box if you know the answer. Yes, I'm waiting for your answer in the comment box. Joe, don't just read and sit. Okay, just try to involve. Yes, a placenta that completely covers the internal cervical os is termed as what we call that one. Okay, so placenta is there which is completely covering the internal cervical os. So what we call that one? Is this a lateral previa? Option B, is this a marginal previa? Option C, is this a partial previa? Option D, that is the central placenta previa. Yes, very nice of you all. So the answer for this question goes to the placenta which is completely covering, okay, which is completely covering the internal cervical os. So that is the central placenta previa. Okay, so remember with this particular diagram what I am explaining you, so it will be very much helpful to you. Okay, so here is the uterus and this is our cervix. Okay, and here we have the very important internal cervical os. Okay, so this is the uterus, this is the cervix, and here is the internal cervical os, right? So here the placenta which is lying in the lower uterine segment, but it does not touch the margin of the internal os. Okay, so cervical os it does not touch. Okay, so you look at the gap. Okay, so yes, the placenta is in the lower uterine segment, but it does not touch the margin of the placenta previa, margin of the our cervical os. So this type of the placenta previa, what we call this one? So we call this one is in the lateral placenta previa. Okay, so what we call this one is in the lateral placenta previa or the type 1 placenta previa. Okay, so we call this one what it is, that is the lateral placenta previa or the type 1 placenta previa. Okay, so very important, remember. So what happened here, the placenta is lying in the lower uterine segment, but it does not touch the cervical os. Okay, so this is the type 1 placenta previa, or it is what we call as the lateral placenta previa. Okay, so similarly look at in the image number 2. Similarly look in the image number 2. So what happened here, so here is the our uterus. Okay, and this is the cervix and this is the internal os. Okay, so now this particular placenta which is lying in the lower uterine segment and it have touched the particular internal cervical os margin. Okay, so this is the margin of the internal cervical os. Okay, so now this particular placenta, this have touched the internal os. Okay, this particular placenta previa, we call this one as in the marginal placenta. Okay, what we call this one as in the marginal placenta previa, or we call this one as in the type 2 placenta previa. Okay, so in this both type like 1 and type 2 placenta previa, so this one we again divided into this particular placenta which is lying in the lower uterine segment in the front, means we call this one as in the anterior. Okay, so we call this one as in the anterior type 1 placenta previa. If that placenta which is lying in the lower uterine segment and which is back side, means we call that one is in the type 1 posterior placenta previa. Okay, so again similarly in the marginal placenta previa, again we will divide this one into the anterior type 2 placenta previa and posterior type 2 placenta previa. Okay, so posterior type 2 placenta previa, very important. Just try to remember the one concept what I am explaining here better. So whenever we will do the ultrasonography, in the ultrasonography or in the USG, you will able to see this particular type 1 and anterior placenta previa you can see. Okay, and type 2 posterior placenta previa you can see in the USG. Okay, then comes to the type 2. Okay, in the type 2 anterior placenta previa you can able to see in the USG, but this type 2 posterior you are unable to see. You are unable to see in ultrasonography. So that is the reason the most dangerous type of the placenta previa is type 2 posterior placenta previa is the most dangerous type of the placenta previa. And why? Because which is hidden and which is undiagnosed and which is undetectable by the ultrasonography. So that is the reason which we call this one as in the dangerous type of the placenta previa. Hope it is clear to every one of you, right? So the next another two type of the placenta previa we have here is, that is our, look at this particular very important images, so it will be very much clear to every one of you. Okay, so here is the image. This is the uterus. Okay, so here is the internal os. Okay, so the placenta which is lying in the lower uterine segment and which is covering the half of the, okay, so it is covering the half of the internal os. Okay, look at this particular type 2 here, it is just covering the margin of the internal os. Okay, in the type 3 which is covering half of the internal os. Okay, and which is completely blocking the half of the internal os, okay, which is blocking the half of the internal os. So this one we call this one as in the type 3 placenta previa, or we call this one as in the a very very important, that is a partial placenta previa. Okay, so very very important one. Okay, so then here the last type of the placenta previa we have here is, that is our a complete placenta previa, or the central placenta previa we can say. Okay, so that is the very very important, remember. So this is the uterus, and here is the our internal os. Okay, so this placenta which will cover completely internal os will be completely covered. Okay, so this is what you call as the complete placenta previa, or the central placenta previa. Okay, so this is our type 4 placenta previa, or we can say complete placenta previa, complete placenta previa, or we can say this one is in the central placenta previa. Okay, so very very important beta. So this is a major type of the placenta previa. Okay, so this one is also a major type of the placenta previa, and here this particular type 2. Okay, so in the type 2, type 2 posterior is the major type of the placenta previa. Okay, and the type 2 anterior is the minor type of the placenta previa. Okay, this is also minor, and this is also minor. Okay, so in the minor grades of the placenta previa, we are having the lateral, anterior, lateral, that is the type 1. Okay, so that including the both anterior and posterior. And in the type 2, only anterior is the minor one. Type 2 posterior is the dangerous one. Type 2 posterior is the major one. Type 2 posterior is the unable to see in the USG, and the type 2 posterior is the hidden one. Okay, so very very important. Just try to keep in your mind. Okay, so now the question is, that is the placenta which is completely covering the internal os. So we call this one as in the central placenta previa. Okay, or we can say this one is in the complete placenta previa. Hope it is clear to every one of you. Right. So the next, you can see the image also. Okay, so this is the normal. Okay, so this is normal placenta. Okay, in the normal placenta, the placenta is, it is there in the upper uterine segment. So this is the normal. Okay, so look at this particular marginal. In the marginal, so it have been covered the which is attached to the margin. Okay, so this is the type 2. This is the type 2, right? So type 1 is the just lateral, which is not attached to the cervical os. Okay, so that is the type 1, that is the lateral one. Okay, so here in the partial you can see. Okay, so this is the internal os, and half of the internal os is covered by the placenta, that is the partial. Okay, this is the type 3. This is the type 3. Okay, so in the type 4, so you can see the placenta which is completely covering the internal os. So we call this one as the total placenta previa, complete placenta previa, or we can say this one is also as the central placenta previa. Okay, so these are the image based questions. So you may directly strike into the exam. So where to focus? Just to focus in the internal os and the location of the placenta. Okay, so if it attached to the margin, that is the marginal. If it at half covered, partial, full covered, total, which is not attached to the margin, that is the lateral. Okay, so hope it is clear to every one of you. Yes, right. So the next question is here. Okay, which is awaits for your brilliant answer in the comment box. Yes, fatafat do comment your answer in the comment box. So this particular question is very very important question for your exam. Okay, so fatafat do mention your comment in the comment box. Yes, Stallworthy sign is associated with which of the following obstetrical condition? Fatafat do response to the answer. Option A, placenta previa. Option B, abruptio placenta. Option C, ectopic pregnancy. And option D, uterine rupture. The question is very simple, and I want everybody's comment in the comment box while are watching the video. So the question is, Stallworthy sign is associated with which obstetrical condition? Option A is placenta previa. Option B is abruptio placenta. Option C is ectopic pregnancy, and option D is uterine rupture. So please do mention your comment box in the your answer in the comment box. Fatafat. Yes. So many of you have given the correct answer. That is the Stallworthy sign, which will be seen in case of the placenta previa. So in which type of the placenta previa? It will be seen in case of the posterior placenta previa. Okay, so it will be seen in case of the posterior placenta previa. Okay, so in the posterior also, in which one, sir? In the type 1 also we have studied anterior and posterior. In the type 2 placenta previa also we have studied anterior and posterior. Okay, so in which one? So mainly this one will be seen in case of the type 2 posterior placenta previa. Okay, so in this particular condition we will get the Stahl-Worthy sign. So what is the Stahl-Worthy sign, sir? Please explain, sir. Sir, I will explain, sir. Please completely focus and listen, sir, because this is the important concept, sir. Okay, so look at this particular image. This is the uterine cavity. Okay, so this is the round structure, not uterine cavity. Here it is your uterine cavity. Okay, so remember, in this particular uterine cavity, what we have studied that this is the internal os. Okay, so here type 2 posterior means which is the marginal and which is present posteriorly. Okay, so this in this particular placenta previa. Okay, so while during the labor process, the fetal head, whenever we will try to push this fetal head down, that time this particular fetal head which creates the pressure on this particular placenta. Okay, that time there is the fetal heart rate variability will happens and fetus will land into the distress. Okay, so this is what we call as the Stahl-Worthy sign. Stahl-Worthy sign means during the type 2 posterior placenta, which is not visible in the USG, and whenever we are trying to push this fetal head, okay, okay, down through the uterus. Okay, so whenever we will do pressure, okay, on the fundus to push the fetal head down, that time it creates the pressure on this placenta, and creating the pressure on this placenta which interrupts the blood circulation to the fetus, because you know from the placenta only the umbilical cord will originate and it will connect to the fetus. Okay, it will connect to the fetus. Whenever we are creating the pressure on the placenta, yes, the blood flow to the fetus will get interrupted. Okay, so that is the reason here the fetal distress will happen. So this is what we call as the Stahl-Worthy sign. So hope the concept is clear. Sir, what happens first whenever we are trying to push baby down, that time which creates pressure, which creates pressure on placenta, which may lands the fetus into the fetal distress. Okay, so this particular situation we call this one as in the Stahl-Worthy sign. Okay, so what we call this one as in the Stahl-Worthy sign. Okay, this is your exam important question, beta. So I'm making a star here, remember. Right, hope it is clear to every one of you. So let's come to the next question. Here's the next question which is there for you. Okay, so please do read the question carefully, completely, and try to mention the best answer in the comment box. Okay, I'm waiting for your answer here. What is the typical appearance of the Couvelaire uterus during the surgery? So what is the typical appearance? Okay, how it will looks like during the surgery? Okay, so why? Because the Couvelaire uterus will be seen after the surgery only. Okay, so without surgery we are unable to identify the Couvelaire uterus. Okay, so how the Couvelaire uterus which looks like during the surgery is your question, and on the Couvelaire uterus there is highest chance of the asking the question. Okay, so remember, so Couvelaire uterus which looks like how? Option A is the pale and the earth-tonic, option B is the firm and white, and option C is the blue or the purple discoloration of the uterus, and option D is the uterus filled with the pus. So what is the correct answer? Yes, many of you have given the correct answer. That is the Couvelaire uterus is a colorful uterus which looks like a blue purplish discoloration of the uterus. Sir, why? Sir, why? So let comes to the concept explanation. So it will be very much clear to every one of you, right? So while explaining the types of the abruptio placenta, I have told there are the two types. Okay, so there are the three types. Okay, so one is that the concealed type of the abruptio placenta. Okay, another one is the revealed type of the abruptio placenta. Another one is the mixed type of the abruptio placenta. Okay, so in the concealed type of the abruptio placenta, what happens means in this particular type of the abruptio placenta. So what happens here? Listen carefully. Okay, this is the uterus. Okay, so here is the placenta. which is actually separated from the uterus, okay, and but it is attached by the margins and which is separated by the center. So this is a concealed type of the placenta abruption, okay. So here behind this particular placenta there is accumulation of the blood is there, okay. So here there is accumulation of the blood, okay. So you know this is a venous blood, this is the venous blood, okay. So this blood which is rich in the carbon dioxide, so this blood which will enters into the myometrium back here, okay. So that is the reason whenever we will see the uterine color in this particular site of the placenta, it will get converts into the, yes, how the carbon dioxide color will get converts. So that is the CO2 rich blood, so which will get converts the particular uterus into the blue color, or it may looks like a purple color also, okay. So this it may looks like a purple color. Why? Because this carbon dioxide rich blood, it will enters into the myometrium and which looks like a purple or blue color, okay. So this is what you call as in the Couvelaire uterus, okay. So what we call this one is in the, we call this particular condition as in the very very important Couvelaire uterus, okay. So remember, very very important point for your upcoming exam. So the three very important point you have to remember in your mind regarding the Couvelaire uterus. So this Couvelaire uterus will be seen in case of the concealed type of the placenta previa, okay. So it will be not seen in the revealed type and in the mixed type. So mostly it will seen in the concealed type placenta, in the concealed type of the abruption placenta. And the second point you have to remember regarding this one is the, yes, this like Couvelaire uterus means no need of the hysterectomy, okay. So it does not indicate the hysterectomy not indicated, okay. It is blue in color, it's purple in color, so remove this one. It's not like that, okay. So Couvelaire uterus means it's a normal situation and it will resolve normally, so no need to remove the uterus, okay. Hysterectomy is not recommended, okay. So very very importantly, so this Couvelaire uterus, so very very importantly, it may causes the postpartum hemorrhage, okay. So increases the risk of the, okay, so the risk of the postpartum hemorrhage will be increased here, okay. In the Couvelaire uterus, the risk of the postpartum hemorrhage will be increased and hysterectomy is not indicated, and which will be seen in case of the concealed type of the placenta abruptio, okay. So very very important three golden points about the Couvelaire uterus, remember, okay. So this Couvelaire uterus will be which looks like a blue color or the purple discoloration of the uterus, okay. This is the very very important point, just you have to keep in your mind, okay. So the type of the our placenta abruptio, one is the concealed type, okay. I told there is the no any bleeding, okay. Concealed means it is attached from the both margins and in the center which is detached, okay, and blood is collected here, right. Are you able to see this red blood behind the placenta? So this is the concealed type of the placenta abruptio, okay. So again the image B, are you able to see the image B? In the image B, this side which is attached, but one side which is completely detached, and whatever the bleeding happening behind the placenta which is coming out through the vaginal cavity, okay. So this is what you call as the revealed, okay. So which is not hidden. Revealed means open, revealed means not hidden. Concealed means not open, concealed means hidden, okay. So very very important thing, keep in your mind. And the mixed one is initially, okay, so initially it was concealed, then after it get converts into the revealed, so that is the mixed one. Sir, among option A, option B, option C, so which one is most common, sir? Already I have explained, sir. So the most common type of the abruptio placenta is the mixed type of the abruptio placenta, okay. So mixed type of the abruptio placenta is the most common type of the abruptio placenta. Very very important point for your upcoming exam, okay. So here is the golden point, chanting and revision on the grades of the abruptio placenta, remember, okay. So this is the very very again very important grades of the abruptio placenta. Just you have to remember here. So grade, it will start from the grade 0 and 1, 2, 3, okay. But in the option in the exam you will get grade 1, grade 2, grade 3, grade 4. So your concept will be ultum palta. Just remember and focus. The abruptio placenta grades will start from grade 0, okay. So this one, it will start from the grade 0 and there are the total 4 grades, but it starts from the grade 0, grade 1, grade 2, grade 3. The maximum grade is grade 3. Okay, so there is any grade 4. Okay, but in the examiner you will get the option as grade 1, 2, 3, 4. Don't get confused. Okay, it's clear? Yes. So what happens, sir? Let me explain, sir, perfectly, so it will be very much easy for you all. Okay, so in the grade 0, what happens? There is no pain, there is no bleeding, and which will be not detected during the what we can say antenatal period. It will be detected after the delivery. Okay, it will be detected after the delivery. Whenever we will deliver the placenta, that time we will come to know that. So this was the abruption placenta. Sir, how, sir? Remember, how means what happens here in this particular grade 0 type of the abruption placenta. Okay, so this is the uterus here. Okay, and this particular placenta, it will little only it will get separates, and whenever it gets separated, so in this particular time bleeding will happens. Okay, in the particular local area, and the clot will form here. Okay, so the clot will form here, means a retroplacental clot is present in the a grade 0 type of the placenta. Okay, so retroplacental clot is present in which type of the abruption placenta? That is in the grade 0 abruption placenta. A retroplacental clot will be there. Okay, so there is little suppression, little bleeding, little clot will be there in the abruption placenta grade 0. Okay, so I told patient is unknown. Why? Because there is no any pain. Okay, so no bleeding also, and retroplacental clot is there, right? So I told it will be diagnosed retrospectively after delivery, means so we will not diagnose this one in advance in the antenatal period. We will diagnose this one whenever we will deliver the placenta at the third stage of the labor. That time, while examining the placenta, we will in that particular situation we will diagnose this particular abruption placenta. We will diagnose it after the delivery. We call this one as the retrospective, means so the previous diagnosis we are doing late, so that is we are coming back. Okay, so we are not going forward, just a diagnosis which we have to made in the antepartum period, so that one we are doing after the delivery. So the initial diagnosis we are doing late, means we call that one as the retrospective diagnosis. Okay, so retrospective diagnosis will be seen in the grade 0, and retroplacental clot will be seen in the grade 0, and no bleeding, no pain, because patient is unaware of this one, so that is the grade 0. Remember, okay, in the grade 1 what happens? There is pain, there is bleeding, and the normal fetal heart sound. Yes, in the question pain is there, bleeding is there, normal fetal heart sound. That is the grade 1. And as grade 2, pain is there, bleeding is there, absent fetal heart sound. Okay, absent or the distressed fetal heart sound. So that is the grade 2. Okay, in the grade 3, pain is there, bleeding is there, and fetal heart sound is absent, plus mother is in a shock. Mother is in a shock. So this is what you call as the grade 3. Hope it is clear to every one of you. Yes. Pain in the abdomen plus bleeding plus normal fetal heart sound, that is the grade 1, and grade 2, that is the pain in the abdomen, okay, bleeding plus absent or the distressed fetal heart sound, that is the grade 2. And in the grade 3, pain in the abdomen plus bleeding plus fetal heart sound absent, plus mother is in the shock. Okay, so that is the a very important point. Just you have to focus here, this highlighted thing. Okay, so this will be helpful for your exam. Hope it's clear to every one of you the classification of the abruption placenta. Yes, sir. Then comes to the next question, sir. Yes. Fatafat, do read the question and give the best answer in your comment box. Yes. Definitive treatment of the placenta previa with uncontrolled bleeding before term is what we can do here. What is the definitive treatment of the placenta previa with uncontrolled bleeding before the term? So what is the answer here? Option A, corticosteroid therapy. Option B, tocolytics. Option C, emergency cesarean section. And option D, iron supplementation and the follow-up. So let me quickly explain the management of the what we can say the placenta previa. Okay, so whenever the patient will comes with the placenta previa, okay, patient with the placenta previa, whenever she will comes to the emergency room, okay, first thing what we will assess her vital signs. Okay, so then we will assess her fetal heart sound. Okay, so fetal heart sound will be assessed here. After the vital signs, what we will assess here? Okay, so after the vital signs, we will assess the fetal heart sound, and then we will assess very important amount of the bleeding. Okay, so how much amount of the bleeding is there, so we will assess. Okay, so these things we will initial management. Okay, I am not talking about the definitive treatment. Just I am talking whenever the placenta previa case which will comes to the emergency room, and here I am talking about the initial treatment, how we have to manage the patient. Okay, so initial treatment I am explaining. Okay, if the vital signs is stable, well and good. Fetal heart sound is stable, well and good. Amount of the bleeding is low, so well and good. If the vital signs is unstable, so immediately, if the vital signs is unstable, okay, so immediately resuscitate the patient. Okay, why? Because here is the, in the placenta previa there will be a bleeding will be there. Okay, initially less bleeding, but after warning bleeding there will be a hemorrhagic, like heavy hemorrhagic bleeding will happens after the warning bleeding. Okay, so resuscitate the patient. You know, as a nursing officer, how we have to resuscitate the patient? Yes, how we have to resuscitate the patient? We will insert the two large bore IV cannula. One is NS IV bolus. Then after that, a maintenance IV fluid we will give. If necessary, we will arrange for the blood transfusion. Okay, so this is how we have to resuscitate the patient. Okay, so then the fetal heart sound is good means okay. If not good means we have to go for the next intervention to save the fetus also here. Okay, so amount of the bleeding is less means okay. If it's more means we have to go for the blood transfusion, right? So this is the initial management how we have to start. Okay. Then comes to the definitive management of the placenta previa. What are the very important focused management we have to do in the placenta previa? Okay, so remember, whenever the patient comes here, okay, so in the emergency department, consider the patient always placenta previa will be the patient will manifest in the emergency department only. Okay, so remember, in the emergency department patient came. Now the patient vital signs is stable. Okay, and the period of gestation is less than 37 weeks. Now no any active bleeding. Now no any active bleeding. Okay, and no fetal abnormality will be there. Okay, so no fetal problem. Okay, in this particular situation we will do the expectant management. Okay, so we will try to continue the pregnancy. Okay, so we will try to continue the pregnancy. We will do the expectant treatment or the expectant management. So the focus is here to continue the pregnancy because the period of gestation is less than 37 weeks. So we want till the 37 week we have to continue the pregnancy. Okay, so this one, the continue the pregnancy is the focus here. Okay, if the patient vital signs is stable, okay, and period of gestation less than 37 weeks and no any active bleeding currently, okay, so no fetal problem also, so the management will be expectant management we will do. So our focus is to continue the pregnancy. Okay, if in case the vital signs are unstable, okay, and period of gestation which is more than 37 weeks, and now patient is bleeding active. Okay, so now active bleeding is present, right? So there is fetal anomaly is present. Okay, so fetal anomaly also, there may be evidence of the fetal anomaly. So in this particular situation, so what we will do, we will try to terminate the pregnancy. Okay, so here we will try to terminate pregnancy. Means terminate the pregnancy means not to kill the fetus here. Termination of the pregnancy means yes, we will start the normal vaginal delivery induction we will do. Okay, so we will do the normal vaginal delivery induction. So that is the very important point, just we have to keep in our mind. Okay, if the patient is having the active bleeding and the fetal distress is there, so instead of the normal vaginal delivery, so we will go the better option here is the very important, that is the emergency lower segment cesarean section. Why? Because now the patient is having the active bleeding is there. So in this particular situation, so I will go for the LSS. It saves the time and it saves the patient. Okay, so that is the very important thing. And the vital signs of the patient is also unstable. If I am waiting for the normal vaginal delivery, so that may be a dangerous to the patient. So that is the reason. Okay, if there is in the uncontrolled active bleeding is there and the vital signs are unstable in this particular situation, so emergency LSCS goes to the best answer. In the question also they have asked a very simple thing. Okay, so now placenta previa patient is there and she is having the uncontrolled bleeding, so always answer goes to the emergency cesarean section. Okay, so in the uncontrolled active bleeding, we can't go for the corticosteroid therapy and iron supplementation, tocolytics here. Okay, so best answer for this question is the emergency cesarean section. Hope the management of the placenta previa is very much clear to every one of you. Okay, so here I told in the definitive management, if the vitals are stable and period of gestation is more than 37 weeks, no any active bleeding is there. Okay, and the fetus there is no any problem. Here I told expectant management and I want to continue the pregnancy. Sir, how I have to do the expectant management? What are the point of the important we have to keep in our mind? So to manage the expectant management, there is the regimen given by the McAfee and the Johnson. So this McAfee and the Johnson regimen is the regimen which is used for expectant management of placenta previa. Okay, so very important. It is not for the termination or it is not for the definitive management. Okay, it is for the expectant management. Okay, so in the McAfee and Johnson regimen, so what he will say, whenever the patient will comes to you with the placenta previa, just to continue the pregnancy till the 37 week. Okay, so what is it same? So now to continue the pregnancy till the 37 week is the aim of this particular regimen. Okay, so here I will hospitalize the patient, means I will admit the patient to the hospital for the close monitoring. Okay, so I want to monitor the patient closely, vital signs, fetal heart rate and fetal distress I want to monitor. Along with that, how much the bleeding is happening, that one also I want to monitor, and the very important fetal well-being also I want to monitor. So that is the reason, so we need to hospitalize the patient. Okay, so then I will advise the bed rest for the reducing the activity and preventing the incidence of the again reoccurrence of the bleeding. Okay, so the next one, I will closely monitor the patient for the vital signs, uterine activity and the vaginal bleeding and the fetal well-being. Okay, so I will monitor like all this very important thing here. Okay, so then I will avoid the distal vaginal examination. I told many time, this is the golden point beta. In the placenta previa, we will never ever go for the digital vaginal examination. Okay, so very important, just keep in your mind. Sir, also you have to keep one extra point here in your mind. So that is we will not do the per vaginal examination, but the investigation of choice, for the very important placenta previa is the transvaginal ultrasonography. Okay, so transvaginal sonography is the investigation of choice for the placenta previa. Sir, how, sir? So insertion of the finger, that is the per vaginal examination is contraindicated, and we can insert the probe. Can we insert the probe? Yes. Can we insert the probe? Yes, we can insert the probe. How? Because, so look at this one. Okay, don't consider the headline, just understand the concept. Okay, so here, this is the uterus. Okay, this is the placenta previa, and here will be the cervical os is there. Okay, so if blindly per vaginally I am inserting the finger, means it can crosses the placenta, so it can crosses the cervical os and it can damage to the placenta. But while doing the transvaginal sonography, so here we will insert the USG probe. That one we will see in the screen. Okay, so that one we will see in the screen. So if it is going to touch to the fetus, if it is going to touch to the cervical os to the placenta, so we will remove it black. Okay, so while doing the transvaginal sonography, we can see where the probe is going, but while doing the per vaginal examination, we can't see where the fingers are going. Okay, so that is the reason per vaginal examination is contraindicated. Okay, so per vaginal examination in the placenta previa. Okay, so in the placenta previa it is contraindicated. Very important, just keep in your mind. But the transvaginal sonography is the investigation of choice. Initial investigation, that is the transabdominal, means the abdominal USG will be done initially, but the investigation of choice is the transvaginal sonography. Remember, for the placenta previa, very important point of the discussion and the concept. Okay, so hope it is clear to every one of you. Yes, is this clear to every one of you? If it is clear, so fatafat hit the like button. Right, so the next point here in the McAfee and Johnson regimen I want to explain. So I told the golden point, avoid the digital vaginal examination until the placenta previa is ruled out and until the cesarean section is planned. Okay, so then we will give the corticosteroids to the mother here to in order to improve the fetal lung maturity in the babies. Okay, so that is the usually betamethasone we are recommending. So there are the two regimens. The one is the dexamethasone regimen, another is the betamethasone regimen. Okay, so I will explain. So how much dose to be given with how much gap. Okay, everything I will explain in the preterm labor and its management. Okay, so don't worry about this one. Okay, so remember in the McAfee and the Johnson regimen we will give the corticosteroid and we will avoid the PV examination. We will closely monitor the patient, bed rest, admission. First admit, then bed rest, then closely monitor, then avoid the PV examination, then give the corticosteroids and blood cross matching, and the we have to make and we have to arrange the blood for the emergency transfusion. And if the patient, if the female is RH negative, if the female or the woman is RH negative, so give NTD or we can say the Rogam injection. Okay, so give NTD or the Rogam injection we have to give to the woman. Okay, so that is the intramuscular 1500 international unit we have to give, or the 300 microgram is the dose of the NTD or the Rogam you have to administer. Okay, so very important point you have to keep in our mind, right? So we are managing the patient and we are doing the expectant management. Suddenly if the heavy vaginal bleeding starts, what we have to do? Suddenly if the vitals went unstable, what we have to do? Suddenly if the fetal distress started what we have to do? Can we wait till the 37 week? No need to wait. If again the fetal distress started, sudden heavy vaginal bleeding started, and if the pregnancy which reaches to the 37 week, you can do the normal vaginal delivery. Okay, so immediately deliver usually by the emergency cesarean section if the bleeding becomes heavy. Okay, and the fetal distress started, and if the pregnancy, our target is to reach until the 37 week. Our target is reached means just try to deliver by the normal vaginal delivery, or if not possible, we can go for the cesarean section. Okay, so usually by the C section. Okay, so very important point. Just try to keep in our mind. Okay, sir, how we have to deliver the placenta previa, sir? So what are the indication for the cesarean section and what are the indication for the normal vaginal delivery? Sir, remember while explaining the types of the placenta previa, I have told that. Okay, so major type of and minor type of the placenta previa. Okay, so here what are the major type? First I will explain what are the minor type. Okay, so the type 1 both anterior and posterior is the minor type I told. Okay, and the type 2 anterior, so this is the minor type, right? In the type 2 posterior and type 3 type 4, so these all are major type of the placenta previa. Okay, so this one type 1 anterior posterior and the type 1 anterior, so these all are the minor type of the placenta previa. So in the minor type of the placenta previa, our treatment is normal vaginal delivery. Okay, so not normal, it's not treatment. The mode of delivery here is the normal vaginal delivery. Okay, so if the patient is having the type 2 posterior and the type 3 type 4 the major placenta previa, in this situation we will go for the emergency lower segment cesarean section. Okay, so LSS we have to go for here. Okay, so very important, just try to keep in your mind. So mode of delivery in the placenta previa. Okay, hope it is clear to every one of you. Yes, so here is the next question which is awaited for your brilliance. So what do mention your comment, your answer in the comment box. So what? Yes, but classes may go lengthy because I want to cover all the very important and golden point for your exam. So the classes length may become somewhat lengthy here. So you have to tolerate this one and you have to go according to this. Yes. Yes. So the question is very simple. A 32-year-old pregnant woman, and now she is at the 34 week of the gestation. Okay, so now she is at the 34 week of the gestation and she presents with a painless vaginal bleeding and she is hemodynamically stable. So what happened here? The 34 week pregnant woman is there and she is having the painless vaginal bleeding. Okay, she is hemodynamically stable. Okay, so painless vaginal bleeding means she is a case of the, yes, she is a case of the placenta previa. Okay, so she is now hemodynamically stable. So what is the next best step of the management? Option A, perform the digital vaginal examination. I told the digital vaginal examination in the placenta previa is the contraindicated. Okay, so painless vaginal bleeding means, so we will suspect this patient as in the placenta previa. So performing the vaginal examination digitally or the digital per vaginal examination is contraindicated. So option A is not a next best step of the management. So this kind of the questions in your Norcet prelims expected. Okay, so try to practice more questions like what is the next best step, next best step, next best step. Okay, so these kind of the questions in the last two Norcet they have abundantly filled in your paper. Okay, so like the nurse is doing that one, that one. Okay, so what is the next best step? Okay, so you have to continue the according to the procedure. So you have to hold the concept in the mind, so your answer will be very clearly manifest in front of you. Okay, so remember, so these kind of the questions will come in your exam, right? So the next option B is the immediately cesarean section. Beta, the patient is hemodynamically stable. Why we will do the cesarean section? So I am eliminating the option B also, right? So the next comes to the administer the uterotonic drugs, administer the uterotonic agents. Beta, still the woman is having the 34 week of the gestation. Now you are giving the uterotonic like oxytocin, means the induction of the labor will start and the preterm labor will happen, and the patient may or the child baby may born with the respiratory distress syndrome and all. Okay, so in order to avoid that one, so I am eliminating the option C, D also. So according to the method of elimination, so the next best step is here to perform the ultrasound. Okay, so beta, so what happened here? So now the 34 week of the gestation is there. She came with the painless vaginal delivery. So first thing I told, whenever the patient comes to our emergency room with a vaginal delivery, so first thing what we have to do, assess her vital signs. Okay, second one we have to do the our fetal heart sound assessment, then assess for the amount of the bleeding. Okay, so then assess for the bleeding amount, how much it happens. Okay, so to assess the fetal heart sound, so you can take a USG help or you can take the Doppler help. Okay, so you can take the USG Doppler help. Okay, so that is the reason if the vital signs in the question only they have given the vital signs is stable. Okay, so hemodynamically she is stable, means the vital signs is stable. So the next best step is the assess the fetal heart sound or to assess the ultrasonography. Okay, so that's the very important question you have to keep in your mind. Okay, so hope it is clear to every one of you. And here is the next question which is coming in front of you. Okay, so sir, if USG is not available, so what I have to do, sir? Yes, if the patient is in hospital, USG is not available, so just I will take the patient to the OT. Just I will take the patient to the OT, and patient I have taken to the OT. Okay, so in the OT what I am doing, I have prepared for the okay, C-section. All the equipment, everything I have kept ready for the cesarean section. Okay, so now per vaginal examination we will do. Okay, per vaginal examination we will do to confirm whether it is in the placenta previa. Okay, so this is what you call as in the double setup examination. Okay, so what we call this one is in the, this is what you call as the double setup examination. So when this one will be done, so this double setup examination will be done whenever there is in the USG is not available in the clinical settings. Okay, so we will take the patient into the OT. Okay, so then we will arrange for the all the equipment for the cesarean section. Okay, so then we will go for the PV examination. Okay, if any active bleeding starts, means just we will do the cesarean section. Okay, so this is what you call as in the double setup examination. Very important point, just you have to keep in your mind related to the double setup examination. Hope it is clear to every one of you. And here is the next question. Yes, the next question is very simple and very important again for you all. Yes, a 34-year-old woman at the 36th week of the gestation, she presents with a sudden painful dark vaginal bleeding. Okay, so what happened here? The 36th gestation, again in the third trimester. Okay, she suddenly came to the hospital with a painful dark vaginal bleeding, and her uterus is tender and rigid, means it is a case of the abruption placenta. Okay, so there is in the painful dark vaginal bleeding is there, tenderness is there, rigidness is there. So I told how to clinically assess this one, right? So that is the case of the abruption placenta. Okay, Now fetal heart sound is absent. Okay, what is the next best step in the management? So this question also will be come in your exam directly. Remember, whenever there is a patient comes to us with the abruptio placenta, with the abruptio placenta, always there is no any wait and watch. Don't wait and watch, because if you are waiting means this may get converts into the disseminated intravascular coagulopathy. So if this patient lands into the disseminated intravascular coagulopathy, so that time it is very dangerous to do the PV like pervaginal delivery also, LSCS also, because in this particular situation the female will bleed abundantly uncontrollably. Okay, so that is the reason whenever the patient will comes to us with abruptio placenta, the next best step of the management is deliver as soon as possible. Okay, so this is the very important next best step of the management. Okay, so option A is the immediate hysterectomy. Beta, why we will remove the uterus? So we will not remove the uterus. Okay, so option C, conservative management and observation. I told don't never ever wait and watch in the abruptio placenta. Don't wait and watch in the abruptio placenta, because the late delivery in the abruptio placenta which will leads to the disseminated intravascular coagulopathy. Sir, how, sir? Yes, let me explain the concept also, so you will be very much clear here. Okay, so I told this is the, okay, so this is the uterus. Okay, and here is the placenta is there, and behind the placenta there is the accumulation of the blood is there. Okay, so this accumulated blood which will release the inflammatory mediators and everything. Along with that, it will activate the our thromboplastin. Okay, it will activate the thromboplastin. Okay, so it will again stimulates the prostaglandin, and which may leads to the contraction, uterine contraction will start, and all the clotting factors, it will abnormally activates, and clotting factors all will be used. Okay, and all the clotting factors are used means there is now no any clotting factor, to stop bleeding. So all the clotting factors are used means, so I call this one as in the consumptive, means all the clotting factors are consumed, means I will call this one as in the consumptive coagulopathy, or I will call this one as in the disseminated intravascular coagulopathy. Okay, so in this situation it is very dangerous. So that is the reason I told whenever the patient will comes with abruptio placenta. Okay, so already contraction have been started, so normal vaginal delivery if possible you can do. Okay, so this is the always preferred method of the delivery is the normal vaginal delivery we will do here. Okay, so the best method of the next best step of the management here is the, okay, so induction of the labor with the oxytocin goes to the best step of the management. Okay, so just we will directly can't go here for the emergency cesarean section. Okay, so very important, induction of the labor with the oxytocin goes to the correct answer. Okay, so hope it is clear to every one of you. This kind of the question may directly strikes in your exam, and my students, the master nursing classes proud students, will very easily, very happily you people will choose the correct answer in exam, because I'm explaining all the rationale concept very easily in very simple language. Yes, this much type of the excellent explanation you people will never get in the YouTube. If you want to search, you can search and come to my channel. Okay, so remember beta, the concept behind the question is the very important to secure the good rank in the exams. Okay, so very importantly, I am running behind the concept as like more than the questions. Okay, so because it actually makes you a champion, and in every aims in India, every aims my students are there, you can ask to them, so how the sir will explain and what is the accuracy and strike rate of the sir in the exam. Okay, so this is my entire experience of the cracking the 17 central government exams, okay, including the recent RRB, everything. So I'm giving you free of cost. Please make utilize of this one, take a note of this one, make utilize this one, and make me proud. Okay, so yes, if my students are getting securing the good rank and placing in the good institutes in India, means I am the most happiest person than as like more than your parents. I will be happier person, because you people are my students and following me regularly and watching my videos without any doubt. Okay, so this is the which creates the extra responsibility on me to deliver a high quality content and to get secure on the good best rank in your exams. Okay, so I will give my best shot from my side. I want your effort to. Okay, so I'm giving 100%. You people please give that 100%. Yes, this time the result will be ours. Okay, so hope it is clear to every one of you. And the next question, so just keep in your mind. Okay, so major complication of the abruptio placenta I have told while explaining the difference between the abruptio placenta and placenta previa, and just now also I have told, so if we are delaying to get deliver the labor, so if we are delaying to get deliver the baby, so there will be a chance of the abruptio placenta. Okay, so which may get lands into the disseminated intravascular coagulopathy. So this is the major complication of the abruptio placenta, very important. Okay, so with this particular management and everything, the today's class ends. Okay, so here are your assignments. Okay, so here are your assignments, so please read the questions carefully, and at the end of the video I want your comment in the comment box. Okay, so at the 34-week pervaginally bleeding is happening, so bleeding is red, bright red in color, and there is no pain. So what is this particular condition is? Okay, so and the second question, the 34-week period of gestation, pervaginal bleeding is happening, that is the dark red in color and the painful. So what is the situation is? Okay, so then the last question, what is the cause of the most common cause of the antepartum hemorrhage? So this is the question number 1 you mention, okay, in the comment. This is the question number 2 you mention in the comments, and this is the question number 3 you mention in the comments. Okay, so already I have explained all these 3 points. Okay, so just I want to assess your retention memory. Okay, so what do mention your answer in the comment box at the end of this particular video. Okay, so hope that today's session is very much helpful for every one of you, and remember this motivational line. So whatever the task is there in front of you, it is not bigger than you, it is not greater than your strength. Yes, it is less than your strength only. If you are working in your strength, you can easily grasp the thing whatever you want, and you can easily achieve the thing whatever you want. Okay, so that's the very important thing, just keep in your mind. And if any one of you are searching for the good and best test series which is planned by the excellent team of the AIMS, okay, so if you want to become a part of this one, I have given the link in the description box to download the master nursing classes. Please do download the master nursing classes and make utilization of this super 60 test series very well, getting all the new image based questions, ECG, maneuver based, nursing foundation, all the image based questions, clinical based questions, practical based questions, everything that you people want for our exams I have ingraded in the super 60 test series. Please do attend the test daily. Okay, and who are already part of this one, don't miss the test series and follow it regularly. Definitely it will give the best result in our upcoming exam. Okay, so hope that today's session is very much enjoyable. Thank you so much for watching the class till the end and believing in the master nursing classes and Mr. Nagaraj sir. So we will meet again in the tomorrow session. So tab tak ke liye, Jai Hind, Jai Bharat, take care, love you all, bye bye.